Hi everyone, welcome to CrownEdge. I'm Dr. Janani and I will be discussing few case scenarios and image-based questions on the topic of pediatric orthodontics. Okay, in the previous session, I had covered few questions already. So today we will be covering the same topic as a live session. So before we move on to the pediatric orthodontics for today's session, I want you to know few facts on this particular topic. If you look at pediatric orthodontics, it is as two subheadings. Okay, it has two subheadings. One is the preventive orthodontics. In the preventive orthodontics, we have space loss and what are the space management procedure. How can we regain space? So all those should be covered under as pediatric preventive orthodontics. The second subheading is as interceptive orthodontics. So in that we'll have how to correct mild anterior crowding or posterior crowding. If there is a crossbite, anterior crossbite or posterior crossbite, deep bite in a developing occlusion. Okay, so these two subheadings I want you to be really thorough on. So when you look at preventive orthodontics, yeah, like I told you about space loss, so you need to know about certain factors affecting space loss. So if a tooth is lost at the earlier stage itself, what are the factors that can affect the space there? If a tooth is lost in the early stage, say it at 5 years of age, if the child has lost his posterior, one of the posterior tooth, so what are the factors that can affect the space loss? So there are certain factors that is given in your textbooks. I want you to go through those factors as well. Okay, and how to maintain that space when the tooth is lost is what we will be covering majorly on in this session. That is, I'll be putting a lot of case scenarios and a lot of images of space maintainers or space regainers you need to identify, and we'll discuss about those space maintainers. Okay, so let's move on to this session today. We had already covered around 4-5 questions in the previous session, so let's continue for today's. All right. So the first question is, a 5-year-old child reports with an extracted mandibular first molar done 2 weeks prior to his visit. All right. So the question that is being asked to us is, what is the consequence if left untreated? The options that are given to us are, the second primary molar tips forward. Option B is loss of arch dimension. Option C can cause impaction of the bicuspids. Or option D, all of the above. So let's go back to our picture. So as you can see in this picture, there is loss of 8-4. Okay, and the child has got this done 2 weeks back. So 8-4 is being extracted around 2 weeks back. So what can be done to prevent this space loss? If you are leaving it untreated, what is going to happen? Okay, so for which you need to know certain things like what will happen, what are the consequences that can happen for an individual tooth loss. So there are certain consequences like for first primary molar, for second primary molar of the mandibular region, for the upper primary molars of the maxillary region. So there are certain things you need to be aware of. So in this case, it's a mandibular first primary molar that is being lost. So what are the consequences that you can expect if this tooth is lost at the early stage? One is this behind teeth, that is the second primary molar is going to tip forward. Okay, so that is one of the consequences that you can see as an early loss of the first primary molar. Second thing is distal tipping of this canine here. So the canine is going to go back to this, it's going to go tip distally in this region. So which will eventually lead to loss of this space. So these two are the major consequences that will happen if this tooth is lost. That is either 7-4 or 8-4 is lost. This will be one of the major consequences. Now looking into our options. So what is the consequence if left untreated? So options given to us is the second primary molar is going to tip forward. Yes, I just did mention about that. Second is loss of arch dimension. Yes, when there is a space loss like this, when there is forward tipping and the distal tipping of the canines, there will be the arch space will be lost. So the dimension, loss of arch dimension is going to happen at that stage. Option C is can cause impaction of the bicuspids. That will also happen because the space here is going to be lost, which will lead to impaction of the bicuspids that is going to erupt in that space. Okay, so option D, all of the above, will be our right option for this question. So you need to remember there are certain consequences for each tooth. For first primary molars, for second primary molars of the lower arch, for the canines, and similarly for the upper arch as well. So each tooth has a certain consequence. So just go through those consequences so it will be easy for you to answer such picture-based question. Okay. So let's move on to our next question. An 8-year-old boy reported with complaint of misaligned teeth. His maxillary arch showed mild anterior crowding. It contained all permanent incisor and all primary molars except the left second primary molar. Now let us see what is the question asked to us. What is the suggested treatment? Okay. So the option given to us are option A, placement of band loop space maintainer. Option B, placement of Nance palatal arch. Option C, placement of a space regainer. Option D, wait and watch for the eruption of bicuspid. So what could be the possible option in this picture? If you look at this picture, what could be the possible option that can happen? If you're leaving it untreated, what can happen in this present scenario? He's an 8-year-old boy, and you can see this area is what I'm mentioning about. Okay. So what can happen? There is contralateral teeth present here. This area is extracted. So closely observe what has happened in this region right here. Okay, I've got a few answers. Let me explain the current scenario first. All right. So first, if you see, he's an 8-year-old boy and there is left second primary molar missing in this region. Okay. Either the dentist had extracted or he just lost his teeth at the early stage. Okay. If you clearly see, there is a space loss that has happened in this region. When you see on the opposite side, there is not much of space as compared to the contralateral side. So there is a clear space loss on this quadrant, right? Now, when you look into our options, what has happened is, what is the consequence if left untreated? The second primary molar will tip forward. I'm sorry. What is the suggested treatment for this? The option A is placement of band and loop space maintainer. Will just space maintainer be enough to regain the space in those area? Will that be okay? Just placing the space maintainer? Not exactly, right? Only with space maintainer, we are not going to just get back the loss of space in this region. Okay. So let us see the option B for us. Placement of Nance palatal arch. No, Nance palatal arch is also one of the space maintainer itself. So that cannot be given. Option C, placement of space regainer. Yes, because there is clearly around more than 2 to 3 mm of space loss in this region. So you need to give a maxillary space regainer for this case. Okay. So before, and option D, wait and watch for the eruption of bicuspid. No, that is not the right option because the bicuspids will not come into its right position if you're going to leave it untreated here. If you're not going to regain the space back, they're going to erupt in different direction. So in that note, a right option for this question would be option C. It can cause impact, it can cause, sorry, 1 second. I'm sorry, I just went back to the wrong slide. I'm sorry. So what is the suggested treatment for this is option C, placement of space regainer. Okay. I'm sorry for the previous slide. I just went back to another slide. So if second maxillary primary molar is being extracted and there is a space loss that you can see here, you need to give a space regainer for this case. All right. So for this case, like I told you, you need to know the consequence of if second primary molar, maxillary second primary molar is left untreated. There are two scenarios that can happen. If the child has lost, leave this case scenario here. Okay, if the child has lost before 6 years of age, before the first permanent molar had erupted already. Okay, just forget this case. I'm just telling you on a note. Okay. So if he had lost at the early stage, even before the first permanent molar had erupted, before these two molars had erupted, if the child had lost the second primary molar already, there will be a permanent damage, permanent space loss that can happen here. It is very difficult to regain the space at that stage. Okay. In case if the permanent molar had already erupted and then the child lost this tooth, it will be a similar kind of scenario where around 2 to 3 mm space loss would have been there. It is relatively easier for us to place a space regain and regain back that space. Okay, so we need to know about these two scenarios. That is the consequence that can happen with early loss of second primary molar. So just go through your textbooks. There are consequences given for each tooth. So maxillary and mandibular are slightly different. So go through each consequences of early loss of each particular tooth, so that it's easy for you to understand very easier. All right. So I'll move on to our next question. What is the possible effect of early loss of canine? Okay. So we have covered mandibular first primary molar with one image. We have covered maxillary second primary molar with one image. Now this image shows there's only loss of canine, that too a unilateral loss. Okay, it's not bilateral loss of canine or unilateral loss that was happened long time back. The loss of canine had happened long time back, and there is a clear space loss that has happened here. So what is the possible effect? What are you seeing in this image because of early loss of canine unilaterally? Can anybody just list out what are the changes that you're seeing in this arch? One thing you need to know is if canine is lost in either of the arches, if let it be upper arch or lower arch, there will be a clear midline shift. Okay, when unilateral or bilateral loss of canine is going to lead to midline shift. Okay, apart from that, they're going to be lingual tipping of teeth. All the teeth are going to tip lingually. Okay, and there is going to be consequently a deep bite in the future. Okay, so these are the consequences that you will see with early loss of canine. Okay, so let us see our question here. What is the possible effect of early loss of canine? So option given to us are deep bite, option B midline shift, option C none of the above, option D both of the above. So what will be the right answer for us? Like I told you, early loss of canine can lead to three major things. Okay, few of you are answering what are the possible effects. Good going. So in that way, it can cause deep bite, distal tipping of the laterals also. It can cause midline shift, and it can cause a lingual tipping of all the teeth as well. All right. So right option to our this question would be both of the above. That is option D. Okay. So this I mentioned it as unilateral loss of canine. Okay. So what can happen as bilateral loss of canine? Can anybody tell me? One extra thing would add up if there is bilateral loss of canine. So if there is bilateral loss of canine, there will be definite space loss here. The laterals are going to tip distally. The first primary molars are going to tip mesially. And like I told you, all the consequences that was happening for the unilateral loss is going to continue the same. With there is a possible effect of impaction of the permanent canines can also happen in worst scenario. So there will be loss of arch perimeter, and blocking out of permanent canines are also seen in case if there is bilateral loss of canine. All right. So I want you to be thorough on this part. Okay. So we have covered maxillary first, the first primary molars, the second primary molars. We have covered the canines. So these three are the major things that majorly affects the arch stability, right? Okay, on a developing occlusion. Anteriors, yes, there will be minor changes that can happen if there is early loss of anteriors, but not significant changes that can happen on a long-term basis. Okay, so they can just ask what kind of, let us see what the question is for us next. So in which of the following space maintainer is recommended for this case? I'll show you both the images once again. Okay. So what should be the space maintainer that should have been given for this image prior? Okay. In order they could have avoided this space loss that has happened here. What kind of space maintainer they should have given long time back? In either of these image, what kind of space maintainer should be given? So our options that are given are A. Nance appliance, option B. Lingual arch, option C. Band and loop, option D. Distal shoe space maintainer. So what can be the possible options? Yeah, it's definitely as lingual arch because your anteriors have also been erupted. So with lingual arch, you will be able to give lingual arch space maintainer in both of the cases, which would be ideal. If the anteriors were not erupted, if the permanent anteriors had not erupted, if it was primary anteriors, primary teeth, you can give bilateral bandal loop here. Okay. After the anteriors erupt, you can change it to lingual arch. Lingual arch can be given only after the lower anteriors have erupted. All right. Keep that in mind. So right option to this would be option B, lingual arch. All right. So let's move on to our next question. Identify this appliance. So what is this appliance? Can someone identify this appliance? The options that I have given here are A. Gaucherian arch, option B. Nance palatal arch, option C. Willet's space maintainer, option D. Roche's distal shoe. Okay, I'll just show you the image once again for you guys. So these are the options for you. So what are the options that have been given for us for this space maintainer are Gaucherian arch, option B. Nance palatal arch, option C. Willet's space maintainer, option D. Roche's distal shoe. I want you to know, let's go from back first. Okay, this image. Okay, Roche's distal shoe. No, it is not a distal shoe space maintainer at all. Willet space maintainer is another name for distal shoe again. Okay, so that is also being ruled out. So option C is also ruled out. Option B, Nance palatal arch. Nance palatal arch is given with a support on the anterior part of the palate. So there will be an acrylic button placed on the anterior part of the palate. So this is also not Nance palatal arch. Okay. So what is the option that is given? Option A, Gaucherian arch is the right answer, and it is another name for transpalatal arch. Okay. So the other name is Gaucherian arch for transpalatal arch. Okay. So in this case, you need to know what are the other names for every space maintainer that you are aware of, like distal shoe. It has another names, a lot of other variant names. For transpalatal arch, there's another name. What are the modifications of band and loop, and what are the modifications of all these space maintainers you need to be really aware of. So another thing that you have to be aware of is the indications for space maintainers. So for this, for example of this case, okay, so why have they given this space maintainer is because there is a unilateral, they want to maintain, usually transpalatal arch is given for a very good indication for unilateral space maintainer. When there is unilateral loss of space, they want to maintain the arch length in that area. So usually they give transpalatal arch in that region. Can be given for bilateral cases also, but most commonly they give it for unilateral cases. Okay. So transpalatal arch is a non-functional, passive, maxillary fixed appliance. Okay. That is used for stabilizing the maxillary first permanent molars. So they take the support of the primary teeth and give a space maintainer in this region. Okay. So you know about all the other space maintainers, the names of all the space maintainers, the indications, the contraindications, and the modifications of each space maintainer. All right. So let's move on to the correct next question. The same thing. Identify the correct statement. This appliance is option A, removable, functional, active space maintainer. Option B, fixed, functional, passive space maintainer. Option C, fixed, non-functional, passive space maintainer. Option D, removable, non-functional, passive space maintainer. So think once again, what is transpalatal arch and Tell me what can be the right answer for this. So a transpalatal arch is not removable appliance. So option A is removed. Transpalatal arch is fixed. It's not a functional one. It's a non-functional one when there is no teeth being replaced for functional purpose. So it's a non-functional one. And it is a passive space maintainer. It does not cause active movement of teeth over there. So option C is the right answer. Most of you have given the right answer in the comment section as well. Good going. So any space maintainer. So just have this thing, like I told you, you need to have these specific things in mind before you move on to your questions also. Okay. Next, identify this appliance. Okay. The options given to you are option A, main space maintainer. Option B, reverse band and loop. Option C, bonded band and loop. Option D is band and bar. I'll get back to the image again. Carefully look at that image. Okay. I'll move on to your options again now. Look into all the 4 options. What is the possible thing that you can think of? Is it reverse band and loop? Is it bonded bar? Is it main? Or is it band and bar space maintainer? If you're giving options. Okay, one thing you need to know is this is a modification of band and loop space maintainer, right? All of you are aware of this. It looks like band and loop itself, but there's some modification that has happened there, right? So this is a mains space maintainer where one half of the wire will be cut off to guide the eruption of the bicuspid in that region. Okay, so this is a modification of band and loop space maintainer, fixed space maintainer only, but instead of the wire prolonging onto the other side, they cut off the wire. They do not fabricate this side of the wire or this side, either buccal or lingual. It depends upon case. Okay, to guide the eruption of the bicuspid in that region. Most commonly, they will not keep the buccal side of the wire. They will keep the lingual side of the wire. Okay, so option for this is option A. It's a main space maintainer. It cannot be reverse band and loop because the band and loop is not in reverse direction. It's not bonded band and loop. It's not a band and bar also. Okay. Remember this picture. It's called as a mains appliance. All right. Now identify this appliance. Okay. Yes, you've seen this picture now. Let's move on to our options now. Again, main space maintainer, reverse band and loop, bonded band and loop, or band and bar. What can be the possible options for this? Look into the picture again. This is also a modified space maintainer, modified band and loop space maintainer. Most of you are giving options. Keep going. Look into the picture again. Carefully look into the picture and then give an answer. Right. This is a reverse band and loop. As you can see, the banding is done on the first primary molars and it has been extended towards the first permanent molar when there is early loss of second primary molar. Okay, so these usually when we give it when there is partial eruption of 6, when you're not able to band the 6, that is a permanent molar, when you're not able to band and maintain the space till this region, you give it as reverse band and loop. Once the permanent molars have completely erupted, we remove the band space maintainer and band 6 and give it as a conventional band and loop appliance itself. Okay, so this is a picture of reverse band and loop. So option B is our right option for this question. All right. Now, this is a case scenario. A 5-year-old boy came to the OPD with pain and recurrent abscess with 8-5. Okay. And after clinical and radiographic examination, 8.5 was indicated for extraction due to the presence of focal radiolucency and resorption. What appliance is advisable post extraction? Now look into the picture clearly. 8.5 has an abscess and they have advised for extraction. All right. So what appliance is advisable post the extraction? Is it option A, intra-alveolar eruption guidance appliance? And option B, band and loop space maintainer? Option C, lingual holding arch? Option D, lingual arch with U-loops. Look into the picture. They're going to extract this. This is partially erupting. It's not completely erupted. It's a 5-year-old boy. Okay. I'm sorry. Yeah. It's a 5-year-old child. So once this is extracted, that is second primary molar extracted, what is the indication? What is the appliance that you would be giving? Also for the previous question, option of crown and loop was not given. So that is why it is called as reverse band and loop was given. So that it is a crown and loop. You are right in that part, but it is a with the options that are given to us, it's a reverse band and loop. One person has pointed out that you are right with crown and loop, but in the image with the options that are being given to us, it's a reverse band and loop. So for this question right now, what is the appliance that you will be giving for extraction of E? Early extraction of E will be the distilled shoe. So distilled shoe, what is the options given to us? Is it intra-alveolar eruption guidance appliance, band and space maintainer, lingual holding arch, or lingual arch with U-loops? So option A is right, intra-alveolar eruption guidance appliance, which is the other name for distilled shoe. All right. So most of you are right with this answer. All right. Let's go to our next question. So know the other names for all these space maintainers. Know if it is fixed, removable, passive, all those variant types like I had put, and also all the images. Okay. So moving on to our next question. What appliance is seen in this radiograph? Okay. Can you all type out the answers for this? Can anybody type out the answers for these? With just the radiograph, they can ask. All of you just keep typing out the answers. What appliance is seen in this radiograph? I had not put options for you guys. So can you all type it out? Okay, they can just put a photo of the radiograph as well, just not the appliance. Like people have been telling, yeah, one of you have mentioned, it's a band and loop space maintainer, which is given for early loss of first primary molar, which is being given in the maxillary arch, I believe. So it is a band and loop space maintainer that can be given. Usually you get confused with crown and loop and band and loop, but here because the banding is done only on the, when you see a radiograph, it is because of the banding that done onto that tooth, it looks like a crown and loop as well, but this is not a crown and loop. The opacity which is seen in this image is clearly of a band, not of a crown. So it is a picture of band and loop space maintainer. You're almost right, but just remember that in mind. When you see a crown on a radiograph, it will be completely opaque. Okay, the radio opacity will be completely different than that of a banded tooth. Okay, so it is an ideal. This is a image of a band and loop space maintainer. Okay, so they can ask any of the radiographs. They can put it as a regainer and ask. So anything, just be prepared with the radiographic pictures also. Right. Let's move on to our next question. Identify this instrument. Okay, so the options given to us are: is it band contouring plier? Is it crimping plier? Is it curved hoe? Is it a band remover? I'll get back to your image again. What instrument is this? I'll get back to your options again. Is this a image of curved hoe, crimping plier, band remover, or a band contouring plier? Okay, if you're giving, this is a Johnson's contouring plier. Okay, this is usually given for contouring the bands. Okay, when you place a molar band, when you have to contour the molar bands according to the tooth structure closer to the gingiva, when you kind of contour occlusal gingivally, this is being done along the lower surfaces of the band. Okay, so this is a image of Johnson's band contouring plier. So there are a lot of pliers for band placement. Okay, both in ortho and in pedo, they're similar instruments for banding. So go through those images. So like I told you, there's a crimping plier, there's a hoe, there's straight hoe, there's curved hoe also. Band remover, band pusher. So just go to all your textbook, basic textbooks have these pictures. Go through all the pictures as well. Okay, because most of the images they just show you this and they can ask you questions like this. Instead of asking identify the instrument, they can ask you what is the use of this instrument also. Then that way be thorough with all the instrument. Okay, so this image is a image of Johnson's contouring plier, band contouring plier. All right, so our option A is the right option for this. Okay, but be prepared, just go back today itself, go through all the other instruments, go through all the pictures. Do not delay it. You'll eventually forget about that, or make a note of it. Go through these pictures as well. Okay, they have been asked in the previous years also, so be very prepared with this question. Okay, this kind of question. Moving on to our next question. Contouring the band along the gingival margin proximally is called, look at the image, what have they done here? What is this procedure called as? Option A, contouring. Option B, festooning. Option D, crimping. Option C, crimping. Option D, walking off plier. What is this image? What is being done here? Okay, most of you wouldn't have been seeing this in a clinical scenario. Okay, but these questions are given in your basic textbooks. These images, these explanations are given in your basic textbooks also. So these things are it's easy and straightforward questions. So contouring the band like this, okay, you're placing the band on the molars. If the contouring is happening like this, what is this and why is it being done? Okay, contouring, festooning, crimping, or walking of the plier. So option for us is, few of you are giving options. Go ahead. So right option for this is option B, festooning. Okay. So what happens in festooning is you contour the band in order to follow the gingival margin, that is proximally. Okay. This is not being done with a contouring plier. You literally cut the band in that region. Okay. To contour the gingival margin proximally. Okay. So the band, it is adjusted so that in the interproximal areas, the band seats really well. Okay, in the caul area, right? Caul area of the gingiva, the band seats really well. So this process is called as festooning. Okay, contouring the band along the gingival margin proximally. That is why I've written proximally here. All right. Whereas contouring plier, you use buccally in all the directions, but mainly proximally. When you do this, when you cut the band in this direction, this curved pattern, it's called as festooning. Okay. So option B for us is a right option. Okay. Contouring is like when you have the band strips, all right? When you have the band material there, you contour them in occlusal gingival direction like this. When you have this in these directions, in this direction, you contour them so that it seats into the gingiva really well. Okay, so gingival margin needs to have a curve, right? You cannot just place the band in straight pattern. So with that contouring plier, if you see the previous image, the contouring plier also has this kind of bulge. So when you place this bulge and keep contouring all along the band, okay, when you do this along the band all over, it kind of seats into the gingiva really well. So that is called as contouring. Okay, when you do it proximally, we cannot just do it proximal because of the caul area. The gingival area is quite high than the buccal and the lingual region. So in that area, you do something called as festooning. You need to make it deeper, okay, so that it doesn't hurt them, doesn't hurt the gingiva in those areas. Okay. So, well, let's move on to our next question. Any doubts in this? Keep putting. I will keep answering either in the end of the session or once as and when I keep seeing the questions also. All right. So let's move on to our next question. A 7-year-old male patient reported with a chief complaint of missing teeth in the left and right, upper and lower region, with a history of grossly decayed teeth for which teeth were extracted in a private clinic 4 months ago. So he's just come and reported with this image. Basically, a lot of teeth were extracted in both upper and lower arch around 4 months back. Okay. So what is the question that is given to us? What would be the best space maintainer for his upper arch in this given image? For the upper arch in this image, what would be the best space maintainer? So what are the space maintainer that you know for an upper arch? Can we just give only band and loop, or should we give anything else? What would be the best ones? So our options given here are option A, transpalatal arch, option B, band and loop, option C, lingual holding arch, option D, transpalatal arch. So what would be the ideal one? You can see there is bilateral. Look at the image. There is bilateral loss of tooth. It's an upper maxillary arch. The anteriors have erupted. What are the things that you can give? So bilateral, think once again. Think once again. Bilateral loss of teeth for maxillary arch. I just mentioned in the previous slides also, there is one indication for bilateral loss of teeth. Okay, let's go on to our option. Option B, transpalatal arch. Usually transpalatal arch is given for unilateral loss of teeth. Okay, it can be given bilateral, but the stability is not as good as for what it is for unilateral loss of tooth. So ideally, transpalatal arch is given only for unilateral loss of tooth. Lingual holding arch is for the mandibular arch, so it's not given in the maxillary arch. Band and loop space maintainer, it can be given, but it's not going to be stable. And as permanent teeth have erupted, the ideal option for this would be option A, Nance palatal arch. So Nance palatal arch will have a acrylic button here and takes the support of the anterior and the posterior teeth. So Nance palatal arch will be given to maintain the space of the lost areas. All right, to prevent the tipping of the molars and to prevent the distal tipping of the anteriors as well. Ideal one would be for the maxillary arches, Nance palatal arch. Okay, so I want you all after the end of this session, please get back to your books. Look into the space maintainer. It's a very, very straightforward, easy chapter. Complete it off just today itself. Do not delay. Now that you've looked into a lot of pictures of all the space maintainers, I want you to quickly go back today, revise all these things. Know the other names, indications, contraindications, and the modifications of each space maintainer. Please be thorough with that. It's a very easy one. Okay. So option for us is for this question would be option A, Nance palatal arch. All right. So next, moving on to our next question. 8-year-old child reports with multiple carious lesion. Due to the internal resorption seen on the radiograph, the dentist decides to extract 7.4, 7.5 and what would be the ideal space maintainer to prevent arch discrepancy? All right. Before I show the options, I want you to clearly, you can only tell off the answers on the comment section itself. You're going to extract 3 teeth. That is this one, 7.5, 7.4 and 8.5. According to this question, they're going to extract it because of internal resorption seen in these 3 teeth. Okay. What will be the ideal space maintainer? This is a lower arch. Okay. And there are anteriors erupted. All right. So once you extract, what will be the ideal space maintainer to prevent arch discrepancy? I want you all to, before I get into the options, I want you to at least tell out few options so that you will be aware of the space maintainer that can be given in the lower arch as well. Right. Okay, let's see the options right now. Okay, we don't have options, right? I'm sorry. So few of you have put right options. Ideally, lingual arch should be given here because the anteriors have erupted. You band the molars. All of you write in this, and you give lingual arch right after the extraction of these 3 teeth. Okay, if anteriors were not there, if it was a 5-year-old child or a 6-year-old child, okay, or anything where the anteriors have not erupted, then you give long band and loop and bilateral band and loop on either side. Once anteriors erupt, you give it as lingual arch. All right. So let's move on to our next question. Identify this appliance. Our options given are removable functional passive space maintainer, fixed functional passive space maintainer, fixed non-functional passive space maintainer. Option D, removable non-functional passive space maintainer. I'll go back to your image again. It's very, very easy one. Easy. Just see the options. Is it a removable appliance or a fixed appliance? Is it an active appliance or a passive appliance? Is it functional or non-functional? Simple. This functional or non-functional? Right. It is a removable appliance, right? It is a passive space maintainer, right? Okay. So those two things, it's very easy. It's a space maintainer. So it's not a regainer. There's no active movement of teeth over there. Okay. So let's move on from our last option. Okay. Removable non-functional passive space maintainer. Is it non-functional or functional? We have teeth here. It's just not acrylic here. So it's a functional space maintainer, right? So it is option D is removed. Okay. Option C, is it fixed non-functional passive space maintainer? No, it is not fixed appliance. It's a removable appliance. Option C is also removed. Option B, fixed functional passive space maintainer. No, it's again fixed. It's a removable appliance. So right option is option A. It's removable, functional, passive space maintainer. When you have teeth, it is functional. When you don't have teeth, it is not functional. That is why all your fixed space maintainers that you've seen, band and loop, all those things doesn't have an active component, a functional component over there, right? So they're all non-functional. This has teeth. It's a functional space maintainer. Okay, keep this in mind. Very simple. They can confuse in a very easy way. So please don't get confused on that part. Most of us will go off into the last option, non-functional. Just keep this in mind. Okay. Let's move on to our next question. Now, identify this appliance. What is this appliance? What is this appliance? Is it active space maintainer or what is it? Is it a active appliance? Is it going to move the teeth, or is it just a passive appliance? What is this? The options given to us are active open coil space regainer, Holtz space regainer, split saddle space regainer, slingshot space regainer. So it's clearly a space regainer. Once you see the options, you're going to move the teeth. You're going to actively move the teeth. Okay. When there is a space loss, more than 3 mm space loss, you usually give a space regainer. Okay. So in this case, what space regainer is this? I'll go back to your options now. Just look into the options now, right? Active open coil space regainer or HOTS, split saddle or oh, good. So it is a active open coil space regainer, right? Because this is a, I'll show you the image. This is similar to fabrication, like how you make a banded loop. The loop is also made in contour with the premolar. Okay, this is ideally given on a first permanent molar when there is tipping of the first permanent molar, when there is early loss of the second primary molar which was there, and the bicuspids are being erupted. To regain the space back for the second premolar to erupt, we usually give this active open coil space regainer. This is usually given only in the mandibular arch. Okay, maxillary arch, we usually don't give this appliance. In the mandibular arch only, we give this appliance. So, in this appliance, we fabricate the band. We have molar tubes attached to it. and we fabricate this wire that I'm showing you here. Okay, and then we put this coil, SS coil, which is slightly more lengthier than the actual length of the inner wire. Okay, we insert that inside, and once we activate the coil, there will be distal tipping of this tooth in the backward direction, in the distal direction. So that's how this act space regainer works. Okay, so the option for this right option is active open coil space regainer. If you see the option B, Holt space regainer is like a lingual arch only. It look like a lingual arch. It's given in the mandibular region. Okay, it has molar bands, same kind of. It looks similar to a lingual arch, but uh, it's a active space regainer for the mandibular arch. Split saddle space regainer and slingshot are usually given as a removable appliance. It can be given in both upper and lower arch. All right. This is a picture of maxillary arch, but usually it's just a fabricated appliance, but usually we give it in the mandibular arch. All right. Is it better to use instead of band and loop? Band and loop is more of a space maintainer. This is given, this is just an image. There's no space loss shown here, but active open coil space regainer is usually given to open the space when there is 3 loss of space already, when the space maintainer was not placed before. To open up that space, we give this. Okay, I'm telling you the indications where usually it is being given, because you're not aware of these. You wouldn't have seen much of cases of these. All right, so in that way, it is better. All right. It is similar to band. It is band and loop is a passive one. It doesn't move the teeth. This is an active space maintainer. It moves the teeth. It will make sure this permanent teeth is tipped backwards in the distal direction. All right. To gain space, it is being given. Okay. So remember something with a coil, and similar to band and loop, it is a active open coil space regainer. Hots will look like a lingual arch. Okay, with molar tubes. Split and slingshot is a removable appliance. All right. So let's move on to our next question. 11-year-old girl reported with chief complaint of a broken tooth in left lower back teeth region since 3 months. Okay. Clinical examination revealed restored 6.5, grossly decayed tooth are 7.5, and root stump at 7.4, clinically missing 4.5, and distally migrated 4.4, and mesially migrated 4.6. So they're concentrating more on the lower arch, I think. Yeah. So they've given the image only of the lower arch. Okay. So there is space loss in this region, very clear space loss. There's a root stump here, there's grossly decayed teeth over here, and the bicuspid is already erupted in this. There's no space for the second bicuspid in this region. Okay, so let us see this is the OPG image, very clearly shown. There is more than 3 space of space loss in this region. All right. So so this is the clinical scenario that they've given to us. Okay. What is the question asked? What is a possible line of treatment? What will you do if a child comes to you at 11 years of age? What will you do at this stage? If you see an OPG image, especially with respect to this image, what will you be doing? Okay. What are the options given to us? You just wait and watch for the bicuspids to erupt, or you give a lingual holding arch, modified band and loop, or a space regainer. In this case, what will you be doing? Will you wait and watch, or we're just going to give band and loop? On the other side, yes, you have to give a band and loop. You will be extracting 7.5 and root stump of 7.4. You can give band and loop to maintain the space. But here, what has happened here is there is already space loss around 2 to 3 Easily the space is lost, and there this has got impacted inside. So, what is the possible line of treatment? Option A, wait and watch. No, you're just going to worsen the condition, because there will be more of lingual mesial tipping of this molar here. Permanently, the space will close off. So it's very difficult orthodontically to gain the space back for this tooth to erupt. So wait and watch is not our option. Lingual holding arch. Lingual holding arch is when you have to maintain the space. Here, the space is already lost. So you cannot give just lingual holding arch for this case. Option C, modified band and loop. No, that is also a space maintainer. You will not be able to gain space with a band and loop. Option D, space regainer, is the right option. Either you can give it as a removable or a fixed appliance, but you need to regain the space and make sure that this tooth is having space to come out, erupt out. All right. So option D is a right answer. Okay. A 9-year-old male patient reported with an issue of irregularly placed upper front tooth. Okay. What is a possible line of treatment to correct the malocclusion? Now, what is this image? What malocclusion are you able to see in this image? Yes. For the previous question, open coil space regainer will be given. Yes. So in this image, what will you be seeing? What are you seeing in this image? Can you name the malocclusion that has happened here in this my region? What has happened here? Is anybody able to identify that? Can you see one of this permanent tooth is palatally placed and the lower incisor is forward? So what kind of malocclusion is this? This is a clear case of crossbite, right? So when the crossbite happens with maxillary, when there is retained upper teeth, it would happen because of that reason also. The permanent teeth has erupted palatally and the lower teeth has stayed in this position, and this is a ideal case of single tooth crossbite, right? So what is the possible line of treatment that you can give? What are the appliances that you know? You remember what you have been doing in your final year? What kind of appliance, what kind of ortho springs that you used to give for crossbite correction? Do you remember what spring you used to give for crossbite? Anybody remember? You used to give an appliance. Sure, it's hidden here, but what appliance will you usually give for this? Finger spring. It is usually for moving the teeth mesially or distally. Finger spring is not to push the teeth forward. Here you need to push this particular teeth forward. So you give a spring called Z spring. All of you remember that? There'll be a Z shaped spring. You open both the coils and you push the tooth forward. Okay. So for this you give, for cross bites, remember you give Z spring. Okay. There are a lot of options for cross bite. Z spring is the ideal one. When you look into crossbite, this is already erupted. The tooth is already come into occlusion. Okay. For this kind of case, you give a crossbite, a Z spring. But if the tooth is just in an eruption state, okay, if the tooth is like this, it's just erupting. Okay. There is you remember there's a method called tongue blade therapy, right? So while pressing with you have these ice cream sticks, you make the patient bite in 45-degree angulation. This is correction of crossbite in an erupting stage. This is for eruption of crossbite in already the tooth that is completely erupted. So crossbites can be corrected in two different ways. One in erupting stage, one in already when it is coming to occlusion. So here it is coming to occlusion. You can give fingers Z spring here. Okay, you can push the tooth like this, and it's going to become like this. All right. But in this case, you don't have to give Z spring. Z spring are not going to work in this scenario much. You can just make the patient bite and stack of 2 or 3 ice cream stick and at 45-degree angulation. That is a therapy called as tongue blade therapy. Tongue blade therapy, you will all be aware of it. So this is for a erupting tooth. That is for already the one which is coming to occlusion. Remember these two. All right. All right. So you got the difference in these two. Any doubts, please put into the comment section. I will definitely answer those. Okay. Now, identify this component of removable orthodontic appliance. What is this orthodontic component of this appliance? Of any appliance, there's a removable this thing. Here, there's a component. What is this thing called as? Options given are palatal canine retractor, helical canine retractor, U-loop canine retractor. Option B, buccal self-supported canine retractor. What are the options that you are aware of? What can be the possible thing in this? Out of your giving options, just keep giving. Answer for this would be, it's a option D, buccal self-supported canine retractor. Okay. In orthodontic removable appliance, clasps, right? You need to know about Adams clasp, C clasp, like that. Canine retractors are of 4 types. Okay. One is palatal canine retractor, helical canine retractor, U-loop, buccal self-supported. This is a image of buccal self-supported canine retractor, which has a coil over here. Okay. It will be around 3 mm in diameter. Once you open the coil like this, when you open the coil in both the directions, the canine will retract the back side, back in the distal direction. Okay. Once you activate the coil, okay, it's going to retract. So this is a this is a canine retractor, and the option for this is buccal self-supported canine retractor. Okay. So I want you all today itself to go and look into all the orthodontic appliance components. You would have fabricated few of these in your final year ortho classes. You would have done C clasp, Adams clasp, springs, labial bows, all those things. Look into all the images right away today itself. They can just put a labial bow, or they can give a split labial bow. They can ask canine retractor. Usually canine retractors we don't fabricate. That's why I wanted you to know about that. That's why I had to put an image of canine retractor here. Okay? Its purpose of it is the same. All the 4 canine retractors does the same work. But this is the image of each of it has its own pros and cons. I don't go into too much of depth of it, but look into the image, know what type of canine retractor it is. All right. So with this, we will be ending up our sessions. I want you all to ask any doubts that you guys have in the comment section. This is like an overview. Whatever I have done is like every topic I've just taken one part of the image, and I just wanted to give you a basic idea of what kind of questions can come. All right. That's why I've been constantly telling you, go back today itself, look into your basic textbook, just flip through the pages of all the images. You will understand, okay, these kind of questions can come. Make a note of these things. Okay, because of late, a lot of picture-based questions, case scenarios have been asked. If you have to answer everything in that, if you want that speed, you need to know about all these things in the everything thoroughly. So in that way, you need to be thorough right away today itself. Start today itself. So I'll just go through all the questions once. All right. So is space maintainer a preventive orthodontics? Yes, because preventive orthodontics. What is preventive orthodontics? By definition itself, it is the actions that you take to preserve the integrity of what appears to be normal at a specific time. So once you extract the tooth, it might look normal that time. You try to prevent the further malocclusion by placing a space maintainer. So it is a preventive orthodontics only. So another thing is, how can midline shift be seen in unilateral? It should be distal tipping, not on the midline. No, when there is unilateral loss of canine, okay, the entire lateral incisor will shift back. You're right. There will be distal tipping, but there will be continuous loss of space in the anterior region also. So eventually there will be midline shift. Definitely you will see a midline shift if there is one loss of. Actually, the midline shift will be worsened in unilateral loss of canine than bilateral loss. Okay, bilateral loss, at least both the side canines are lost. The midline area will not shift on either side. But on unilateral loss, it will be evidently seen as a midline shift. I think I've answered quite all the questions that has been given. Any doubts anybody has, please put in. Like I told you, these are not short questions that can come, but it's more of it can just broaden up your thoughts as well. It will broaden up your ideology of how to prepare the questions for case-based scenarios, right? So in that way, just go through all the images, just be thorough with all the space. It's just a small topic completed today. Likewise, all the topics, whenever you're covering what else can come as image-based questions, just keep going through that as a case scenario, right? Any questions, any doubts, please put it. Yeah.